Hi, everyone. Welcome to our overview of the new benzodiazepine FDA guidelines, which sounds like a dry topic, but to make it more fun, we have Dr. Steve Wright with us today. So just to let you guys know, Steve Wright, MD, is a residency-trained family physician for 38 years. Although no longer providing direct medical care to patients, he remains active in addiction medicine for 33 years and medical pain management for 17 years. He has a particular interest in benzodiazepines, is actively involved in the Alliance for Benzodiazepine Best Practices, the Colorado Benzodiazepine Action Workgroup, and the Schreiber Research Group. He has presented continuing medical education on benzodiazepines more than 50 times and has been involved in several publications on the topic, including the book, The Benzodiazepine Crisis, The Ramifications of an Overused Drug Class. And just real quick, Steve, where can people get this book? Is this a book that patients are going to want to read or their doctors?
Well, if you're really interested in benzodiazepines in sort of a geeked out way, this is a perfect book for you, but there's a lot of information in there that's very readable as well, including on the withdrawal process and what to do and how prescribers might be able to be helpful. This is available through Amazon and, of course, the Oxford University Press.
Great. Yeah. And if you want to learn more about that, people can go to benzo reformorg, which is the website for the Alliance for Benzodiazepine Best Practices, of which Steve and I are a part. As I mentioned earlier to you today, Steve, you are brought back by popular demand because people really liked what you had to say last time. And I think it just is very telling when patients really want to hear from a doctor who not only understands this problem, but can sort of be their advocate for what they've gone through and their advocate on behalf of them to the medical community in general.
Yeah, and this is really not about me. It's not about the Alliance in and of itself. It's about the benzodiazepine survivors who brought this forward to us. And we're advancing the information to the rest of the world, hopefully, to pay attention to the concerns that have been out there for decades. And frankly, a lot of us weren't paying much attention over many, many years, and that's got to change.
And I know that you guys have really stepped up at the Alliance and done continuing medical education courses and things like that. You presented in Las Vegas at the, what was it, Pain Management Week?
Pain Week, yes.
Oh, Pain Week, yeah. And of course, a lot of the credit of getting these warning labels changed goes to a lot of the people working, patients who've been through this, and others working with the Benzodiazepine Information Coalition. They really had a real concerted effort really to help patients report to MedWatch.
That's exactly right. The real reason that the boxed warning has come out is because of the survivor community and posting their lived experiences to the FDA through the MedWatch system. It was interesting. Bernie Silvernail at the Alliance took a look at the number of reports going to the MedWatch system and found that I think until about 2016, 2017, something like that, there were actually more reports for benzodiazepine adverse reactions than there were to opioids. And so that caught the attention of the FDA. And I really credit the Benzodiazepine Information Coalition for having posted the recommendation to survivors that they provide those reports to the FDA. And that's really the only reason we're here. It's not through other kinds of efforts. It's through the survivor community that made this particular difference. And that's important to realize. We think that things move along slowly, and in fact they do, but they don't move along at all unless the survivor community jumps in as they have. And credit to all of you that we're here today to be able to speak to this.
And it makes sense that more people would have reported adverse effects from benzodiazepines as opposed to opioids because the adverse effects are far more varied. Opioids, it tends to be, the main focus tends to be addiction, Whereas the majority of the problem with benzodiazepines is not addiction, but rather for people like me and the majority of people involved in this movement, it's people who have taken these medications as prescribed and have been harmed by them.
That's exactly right. That's exactly
Yeah. So yeah, and also I just wanted to have you explain to us, how much of an impact does something like this, the FDA putting this out, actually make on prescribing practices?
We don't know. And in fact, we're somewhat disappointed when we see some of the literature on other medications and the effect of boxed warnings being introduced and what's happened to them. For example, the fluoroquinolones, there was a boxed warning that came out in relation to fluoroquinolones several years ago. A follow-up study indicated that there was really no change in the trajectory of prescribing of fluoroquinolones, which is an antibiotic, which a lot of people in the benzodiazepine community will know about because of its adverse relationship to benzodiazepine withdrawal. But there was very little change in the prescribing of that. And I think it has a lot to do with how that information is or is not deployed to the prescribing community. What the FDA is planning to do with the boxed warning for benzodiazepines right now is actually nothing. They have no particular plan to put it out there other than the announcement that they provided September 23rd last year, 2020. And we at the Alliance are trying to formulate a project to look at deployment of this information more widely so that prescribers are aware of it. It's just a blip on the screen when you hear from the FDA, oh, we've got a new boxed warning, and then it kind of disappears. But we think that deployment of this information and the application of this in regular practice is going to be really important to change the trajectory of prescribing.
Yeah. And while you take care of that on your end, unfortunately, as has always been the case in the past, it's really going to be incumbent for many patients to educate their doctors, to take this information into them and say, hey, look, this is actually a really big deal. Pay attention.
That's exactly right. And for those that are interested, you can go to benzoreform.org, the Alliance website. We actually have a series of pamphlets for patients that can take to their prescribers to deliver this information indirectly, and we encourage people to do so.
Absolutely, because it can be really hard as a patient to know how to communicate with a medical professional when there's this big sort of power dynamic imbalance going on. So that's a really valuable resource that I highly recommend to people.
Yeah, it's true, and it's unfortunate that many of us out there, many physicians and other prescribers, have this M-deity syndrome. You know it all, and you don't. And and in fact, that we see changes to at the fringes in terms of prescribers with a willingness to listen and pay attention to patients that are having these challenges that are not well described in the literature, frankly. And to the credit of prescribers, we haven't seen in the literature the kind of concerns that are well described in the benzodiazepine communities. We're trying to change that as well, by the way. And so, as difficult as it is, everyone must recognize that the literature is not robust on the kind of challenges that a lot of folks are experiencing.
Well, let's take a look at the literature that we do have from our own government here in the United States and explain it a little bit so that maybe patients do have a better understanding, and maybe their physicians will also have a better understanding of what these drugs really can do and are doing to their own patients.
Yeah, why don't we walk through what the FDA is requiring now for the benzodiazepine class in terms of the boxed warnings. There are now 3 bullet points that are highlighted in the boxed warning for benzodiazepines as a class. The first is the one that was introduced in 2016. It's been around for a while, and that is the co-prescribing challenge of opioids plus benzodiazepines being a particular risk. We do know that at least about a third of individuals who die of an opioid-related overdose also have benzodiazepines on board. Typically, benzodiazepines by themselves do not cause an overdose death. They can, but it's usually in conjunction with something else like an opioid or alcohol or something like that. But together, we see a very strong association between benzodiazepines and opioid-associated deaths. And that's what prompted the warning in 2016. Well established, very appropriate, and really important. The second bullet point is actually that there is a non-medical use and addiction that's associated with benzodiazepines. That's true. That's not necessarily the most important problem that we see numerically out there, but it is true. We see about 10% of individuals that are on benzodiazepines might use them non-medically. They amplify the effect of opioids. They amplify the effect of alcohol. They also soften the side effects of stimulants and withdrawal and that sort of thing. But that's not the most important. And the third bullet point is actually what they call physical dependence, but I call physiologic dependence, which means there are mechanisms in the central nervous system that have both physical and psychological ramifications as a result of discontinuation.
Yes, and I was really happy to see that the FDA did go in and define abuse and also separated that out a bit from misuse, which is, maybe somebody's not abusing it to get a high, but they're not taking it as prescribed, possibly because they're trying to self-medicate some of these adverse effects that are going on. And then they did define dependence as something separate, which in my experience in dealing with thousands of people online every day, every year, that is by far the vast majority of people that I encounter. I do encounter some people who do abuse or misuse here and there, but it's a very, like you mentioned, it's a very small minority. And something that I'd like to point out too that the FDA did say is that physical dependence can occur when benzodiazepines are taken steadily for several days to weeks, even as prescribed. So we're not talking about that this is something you've even been taking for years. And often what I have seen from patients is this misunderstanding by medical professionals that if you've only been taking it for a couple weeks, you can just stop, like you're safe. You can just kind of cold turkey and you'll be fine.
Yeah, we would like to change that, that kind of understanding as well. I've seen reports by individuals that even 7 days of use, physiologic dependence actually occurs, and significant withdrawal, and the downstream consequences can be quite severe. Now, this not is in the majority of circumstances, but it's enough out there that we should be thinking carefully about initiating in the first place, duration of use, and careful discontinuation process as a result of it. So it was great to see the FDA provide the information that it did. We would have loved to have seen the addition of limiting use to 2 to 4 weeks, but that hasn't happened yet.
And that's the other point I wanted to bring up. So the next thing that they say in here is that benzodiazepines are approved to treat things like generalized anxiety disorder and insomnia and seizures, which are long-term problems usually, right? These are not 2 to 4 week problems. So there, how do we balance that out?
Yeah, so there is a term out there called heuristics. And heuristic refers to the way we make medical decision making when there is insufficient information or there's information that's not easily accessible. And so you can look at it as sort of a shortcut, if you will, but that's kind of minimizes the importance of it. All of us in the prescribing universe have to use a decision-making process fairly quickly because we have a patient that we see for 20, 30 minutes, unfortunately, and then have to move on to help other individuals as well. So the decision-making has to occur in a relatively short and easy way to do this process effectively and safely for patients. And what I would like to suggest to the prescribing universe is that once the decision is made that a benzodiazepine is important in a circumstance, and when I say important, it has to do, there are a couple first line indications like alcohol withdrawal, using it for anesthesia for certain circumstances, for crisis level anxiety where somebody is functionally affected, not just bothered by anxiety or bothered by insomnia. But once a decision is made for the purpose of using a benzodiazepines, at the same time, make a decision for an alternative treatment to start that. And so at the same time you write the script for the benzodiazepines, if indeed you are doing that, you write the prescription for maybe another medication, but more importantly, a non-medication alternative so that you can get to, say, cognitive behavioral therapy, because it takes a little time to get in. It takes a little bit of time for it to start being effective. But if you do it at the same time as the benzodiazepine prescription and then follow up at a 1 week period of time to see how are you doing, are there side effects, et cetera, to the benzodiazepines, did you get into to the therapist to start cognitive behavioral therapy or start the other medication, and get those things underway so that when you hit that 2 to 4 week mark, you can more easily discontinue the benzodiazepine because the other thing is going. That's the decision-making process I think really ought to be invoked in the decision-making of using a benzodiazepine if and when we do.
I agree. That would be far more effective, I think, in the long run, because while these medications are approved for treating these things, the data would suggest otherwise as far as are these going to be really that helpful long term.
It really is true, and I know we sound like a broken record, but it really is true. The problems with prescribing long term are very seductive in the sense that, oh, it must be working because when I start to remove it, those symptoms that I was treating at the beginning tend to get worse. Well, that often is not the underlying medical condition. It's a withdrawal phenomenon. And so it makes you, however, as a prescriber, it makes you think, oh, I still got to use this agent because this medication, when I remove this medication or taper down on this medication, it bounces back up in severity. So I must go on for a long period of time. Also, we don't have an understanding a lot of times about the side effects. Individuals, I run into them not infrequently, that have discontinued benzodiazepines who inform me they were not aware of the side effects until the medications were reduced. Their cognitive fogging and things like that. It slowly occurs over a period of time and you don't know that it's happening. Oh, I'm getting older, or this, that, or the other things might be going on. But with removal of the agent, you can see that more clearly. And so for all individuals using benzodiazepines for 2 to 4 weeks or longer, I recommend give it a try to discontinue, tapering very, very slowly with supportive help to see if indeed that might be true in your particular circumstance.
Yes, and that brings us to the next point where, and I think one of the most crucial things that the FDA has finally come out and acknowledged, which is to reduce the risk of acute withdrawal reactions, use a gradual taper to reduce the dosage or to discontinue benzodiazepines, and that no standard benzodiazepine tapering schedule is suitable for all patients. So create a patient-specific plan with ongoing monitoring for severe or worsening symptoms. Could you kind of just elaborate for us, what does gradual, what does slow mean?
Well, that's the critical issue, because I see papers out there saying gradual reduction, and in the paper itself, they drop it by 25% every 2 weeks. And it's just like, that's not gradual.
No, but that's standard. I mean, across the board with patients, that's the standard protocol that doctors follow.
I know, even in some of the guidelines out there as well. So what I think, in my sorting through all this process, and there are no prospective, well-designed studies to say what is the best gradual rate that ought to be there. I suggest that a very, very small reduction take place at the front end, perhaps less than 5% of the original dose as a starting point. And if it's very easy, you can enlarge on that. If it's challenging, you can make it smaller or stretch out the interval between one reduction and the next one. But that's really what I would suggest, less than 5% at the front end. Don't think of this in terms of like the opioids, probably reasonable to be able to come off of opioids in about 4 to 6 months, but really think in terms of 1 to 1.5 years for benzodiazepines, because that's more likely what it's going to take. Certainly is true for a number of individuals, and actually far, far longer for some individuals that take years to be able to accomplish that.
And that actually goes to another part of what the FDA has put out, which is that doctors need to warn patients. They'll often, medications will say warn them about the potential risks for addiction and abuse, and I think there is an awareness of that. But what would it look like for doctors to actually inform their patients about the risks of dependence and slow withdrawal?
I think that's so important. So informed consent is really a centerpiece of medical practice, but in terms of actual application of this, we don't do a very good job of this. We are in the process of developing, actually we have the text now for the informed consent that we think in general would be appropriate to be used for patients. And informed consent is not simply a document that we hand and you sign as an individual who's receiving a prescription, but is a discussion that occurs in association with that as to exactly what that means. So yes, there is the possibility of non-medical use, there is the possibility of misuse, there is the possibility of addiction. That ought to be discussed and explored, as well as the side effects. But the most important side effect, if you will, is physiologic dependence and a description about that. And we hope to be able to deploy that written document soon so that it's easy for prescribers to have available through a variety of websites, the policy and guideline programs that a lot of states have about opioids. This might be attached to that and so forth. But it is really a discussion specifically about what does this mean, physiologic dependence, and what that might mean in my life. And does that mean that maybe I shouldn't even take a shot at starting the medication in the first place, but certainly limiting it, the duration of use?
Yes, and I think in order for doctors to be able to inform patients about that, they have to understand the potential consequences themselves. Just to start off with, the FDA has said that benzodiazepines work by binding to GABA receptors to slow brain activity. So this is why if you start taking a benzodiazepine, you may not be able to drive public transport or do other certain things, because they literally kind of slow down your response time in your brain. And that's why the elderly tend to fall, or, accidents happen and things.
Absolutely. Think of childcare,
Yeah.
just being able to respond to a very active child in your home environment where you might think otherwise that it shouldn't be a big problem. Benzodiazepines, really think of it as slowing everything down. And so things that you might need to be able to be prompt and clear and sharp about, it may slow you down in that regard too. And so it doesn't just slow down one thing, anxiety, or help you with sleep alone, it slows other things down as well.
Right. And then some of the other things they mentioned that are considered normal withdrawal reactions are abnormal involuntary movements, anxiety, blurred vision, memory problems, irritability, insomnia, muscle pain and stiffness, panic attacks, and tremors. And then it says contact your doctor if you experience something really severe, which is catatonia, seizures, delirium, or delirium tremens, depression, hallucinations, thoughts about killing yourself, mania, and psychosis. So it's like, okay, these are the acceptable, what we consider acceptable withdrawal. And then there's the not so acceptable. So I think it's really important for patients to understand, like, it's not a guarantee that your withdrawal is going to be horrendous, especially if you start off with a slow, appropriate taper, much of which I demonstrate on my channel, because unfortunately these medications aren't often designed, the most common medications that the FDA says are being used, which are Xanax and then Klonopin and Ativan. Those are not designed to taper in the way that you have recommended by such small percentages, because they pack such a high dose into such a little pill.
Yeah, those are particularly challenging, the high potency benzodiazepines. And so consideration should be made to use of a longer acting benzodiazepine, where the equivalent dose of, say, diazepam allows for much smaller reductions in a simpler way. I mean, to move 1 milligram of clonazepam is an extraordinary reduction, but 1 milligram of diazepam, not so much, and is much more easily accomplished with the products that are out there.
Yeah, and I think it's telling that the one thing the FDA did not say is there are bad benzos. Don't use the bad benzos to withdraw your patients, right? And there does seem to be, though, this kind of I don't know what you would call it, just this general misinformation out there, or misunderstanding by medical professionals that Valium is the bad benzo, and so we don't prescribe Valium, we prescribe these newer, better benzos.
Well, it's a real challenge, and everybody's different, and so you have to, sometimes it's a hit or miss thing, and unfortunately, we don't have a lot of data to say which is the safer option, which is the more likely to be successful in terms of the trajectory to discontinuing an agent. It's a trial and error situation, unfortunately, and we're stuck with that right now.
Yeah, and that actually brings me to the next point, which is that it says that we need to assess patients' risks for things like abuse and addiction, which there do seem to be a lot of tools out there for that now. But what we are lacking is an assessment tool for those who are at risk for this severe dependence, physiological dependence, and long-term withdrawal syndrome. But in my experience, there are some telltale signs. I mean, you can assess whether or not a patient has been on and off of benzodiazepine before, because if they have, or if they've ever cold turkey something, or alcohol, then their risk does increase, because we have that kindling effect. I've noticed also if patients have also taken other medications concurrently, or like you mentioned earlier, fluoroquinolones, that can also lead to more severe withdrawal symptoms. Do you think that will ever be possible for doctors to assess patients for risk with regard to this?
I think it's going to be possible, but it's a long time coming. I would also highlight another indicator, and that's interdose withdrawal as a indicator of problems ahead. Interdose of withdrawal means that, of course, with the shorter acting, well, not necessarily all short acting benzodiazepines, but as you are approaching the time the next dose is due, are you having symptoms that might be correlated to withdrawal? And if indeed that is the case, that probably is somewhat of a kindling phenomenon, where you're hypersensitizing the central nervous system, so that the benzodiazepine that you took earlier this morning, later in the afternoon, no longer is effective in the way that it was intended to be, and you start having a withdrawal effect. Individuals that have that kind of experience, that's usually an indicator of withdrawal challenges ahead when the tapering process takes place.
Absolutely. And that would be so crucial too in providing appropriate care and avoiding misdiagnosis and misprescribing that often happens, because doctors aren't trained to look as the drug as the source of the problem. And so when new problems arise, or all of a sudden in the afternoon, this person's in a lot of pain, or they're having infections or whatever, because we know now, especially with a lot of the research that Dr. Bob Rafa did, benzodiazepines can kind of affect everything and anything. So you're going to have these really strange symptoms that crop up. And if we could address interdose at the very least as a potential problem with these medications, and look at those symptoms as a potential consequence of taking these drugs, I think we could avoid so many more complications down the road with that.
And it's not just the strange symptoms, it's the pattern of the symptoms as well. You
Mhm.
know, the waves and windows that a lot of your viewers are very familiar with, we in the prescribing community are not. We are very much used to addiction prone substances. And this is addiction prone, and I don't mean to say that that's the big problem with benzodiazepines, but addiction prone substances, when you withdraw, there's sort of this slow reduction of symptoms over a period of time. There might be a post-acute withdrawal phase that may last a year or so, but usually it's just this descending curve, very smooth, and I'm better and better. I may have a few days not as good, et cetera, but this general descending curve. Well, with benzodiazepines, that's not necessarily true. The waves in the windows, of course, waves of increased symptoms for no obvious reason, no particular trigger necessarily, for hours or weeks at a time. And then it gets better and then it bumps back up. We're not used to that. And so in your conversation with prescribers, I think it's important to keep that in mind. And if they see this as really, really peculiar, they may be thinking that this is an entirely different medical condition,
Mhm.
that you have a psychological problem or psychosomatic. Somatic symptom disorder is sort of the new terminology in that regard. They may start to attribute to something else and move away from consideration that benzodiazepines are the source of the problem. So you have to have care in that conversation. And one of the most important features, I think, in terms of looking for a prescriber that is going to work with you, is that understanding, willing to listen and really authenticate and validate your experience as being connected to benzodiazepines rather than something else, and end up going down the wrong track for taking care of the problem.
Yeah, and I would hope every patient would have encounter a doctor who is willing to listen like that. One of the things that the FDA does also recommend is if somebody perhaps was getting off too quickly or whatever, to raise the benzodiazepine to the previous dosage and then proceed with a more gradual taper once stable.
It's possible. I mean, we don't recommend doing that very much because the concern about kindling can be there, which means that kindling is a phenomenon that was originally described in relation to alcohol. Individuals having repeated alcohol withdrawals tend to have a bigger problem with coming off of alcohol the next time. Same thing appears to occur with regards to benzodiazepines. And so if you're jumping between doses a lot, that can end up hypersensitizing the central nervous system in such a way that the next time you try to reduce is much more difficult. So updosing, using so-called as needed additional benzodiazepine doses to cover the symptoms. While that can work temporarily, it can work against you when you're trying to come down that next time. And so it may be appropriate to reinstate, but it ought to be considered very carefully and more or less as a last resort. What do you think, Jocelyn?
I think just use caution. It's totally on an individual basis, and there are definitely people who have benefited from updosing because they just reduced way too fast, and then they're trying to taper off of like 2 milligrams of Valium, and their entire taper is just horrendous to the point where it's almost pointless. So yeah, it's everything in this is a bit of a risk because we're always kind of the guinea pigs because we don't have the research, we don't have concrete information. So it's a matter of trial and error.
Yeah, and that's true. Even if we were to have the research, there's so much individual variability that you can't predict on research. When you think of research, research is sort of like what happens to the generic patient. It's sort of the average of a group of patients that doesn't take into consideration that each one of us is different. Our physiology is different, our neurophysiology is different, all of those, our metabolism is different. So you can't predict necessarily what's going to happen to the next person, you know, and that happened even with the Ashton manual, where those schedules that she provided were felt to be kind of fixed, and that fixed schedule isn't going to work for everybody. She very wisely indicated that these fixed schedules weren't necessarily going to work for everybody either. But a lot of people took these fixed schedules and just ran with it and had difficulties for some individuals by applying those to all circumstances. And that's just not going to work out for everybody.
Yeah, and I think that just comes down to the main point of this, which is everybody's symptoms are going to vary. Every patient is going to look different with the symptoms they present. Every taper is going to look different based on that patient and their drug history and the severity of their symptoms and so forth. So
that's exactly right.
Yeah, it's a lot more work. Benzodiazepines are a lot more work to take and a lot more work to stop taking.
Oh boy, yeah. Too bad we're in this nightmare, but we're working on a pathway to get out.
Right. And that is something that the FDA did mention, which you touched on earlier, which is if a patient has this condition and you're trying to manage this, really provide information about non-drug alternatives. Because once again, once somebody's that sensitized and they're dealing with all these physiological issues, adding in more medications, while for some patients can be helpful, a lot of times can actually just complicate this even further.
That's so true. I mean, you may end up with an agent that you have to taper as well. And keep in mind that anything that affects GABA, the GABA receptor, is likely to be a challenge in the end as well. Think of it in those terms. That's not necessarily true, but it's true enough that care really ought to be provided. And that includes so-called natural products like valerian. The valerianic acid in valerian actually has a GABA effect. And so that can be a particular challenge. I am kind of interested, well, I am interested in lavender in particular because we know that the chemicals in lavender do not affect GABA, yet they can help with anxiety. And so that to me is an attractive alternative. But yeah, non-medication, and I would include natural medicines in that regard as well. Non-medication of processes, far better to consider if they are effective for you as an individual. That's the way to go if you can do it and find providers that are able to support you in that process.
Right, because a lot of times I think patients tend to lose faith in the medical community, in the pharmaceutical route, and so they will look for these natural alternatives, many of which, even chamomile and just anything from that ragweed family may impact those GABA receptors, and we just don't know how helpful versus sort of that much that might inhibit the healing of those GABA receptors in the long run. So that's kind of most of what's in what the FDA has put out. But along those same lines, I just wanted to touch on this real quick because you are a cannabis expert. You do go around and teach other doctors about cannabis. So how good of an alternative is that on the front end? Before prescribing a benzodiazepine, is that a better alternative? And on the back end, for somebody who is having real difficulty getting off or tapering slowly, they're just having such severe symptoms, is that an option? How good of an option might it be?
Yeah, that's a particular challenge. Cannabis is also an area where we have very little research and know very limited amount. What we do know is that it appears in some ways to look like benzodiazepines in some ways. Seems to help at the front end, but when you look at data for individuals with anxiety disorders over the long term, they seem to be having more troubles when they're using cannabis than not. And so it's not clear that it's an alternative that is useful. Neurophysiologically too, we know that cannabinoids do affect the GABA receptor. And, anytime I see that, my alarm bells go up and I'm concerned about it. 20 years from now, we don't want to be sitting here saying, well, sorry about that. It was a bad idea for cannabis too in this regard. On the back end, use of this for an alternative or as a pathway to discontinuing benzodiazepines, there too, we do not know the answer in relation to that. Now, that being said, there's anecdotal information that some people have done okay with cannabis products related to anxiety and related to withdrawal syndromes, but it probably is not a pathway that I would resort to early on in the process in any case. Once again, we just don't have enough information to tell you that it's a good path or necessarily a bad path all the time.
Well, thank you though for, letting us know what you do know about that. And I think what, again, this kind of boils down to is when it comes to these long-term problems, whether it's insomnia or anxiety or, pain even, but maybe pain less so, that these problems aren't really um aren't pill solved types of problems. In the long run, a pill may be something that can be kind of a good crutch that can get you through a really bad time, but long term, pills just probably aren't the solution. Or even in the form of cannabis, whether you're ingesting it in other ways, a substance just isn't really long term the best solution for a problem like anxiety.
Yeah, I would agree with that. More skills, less pills, I think is the way to go. And we tend to categorize natural products and pharmaceutical company based products as being separate. But for me, the definition of a medication is a substance used to solve a problem. And if you're using a natural product to solve a problem, that's using it in a medication kind of way. For me, it's lifestyle, it's self-management, it's working with professionals who are using non-medication approaches that really ought to be the heart and soul of the kind of things that we do for neurophysiologic processes, processes that involve the central nervous system. There seems to be a difference between medications that we provide for individuals for peripheral outside of the central nervous system process like blood pressure and diabetes. There you can take short-term studies and translate that into long-term outcomes that are typically favorable. But neuroactive agents, there's an adaptational process that takes place. The brain is constantly trying to take you back towards anxiety or towards insomnia every time you introduce a product like a medication, a pill or a natural product to drive it in one way or another. And so far better than pills, if you can be successful at it, the skills are the way to go. Now, that being said, if you are functionally disturbed, overwhelmed by the symptoms that you're having, medications have a role for that circumstance, hopefully a temporary use of those medications in that regard. But it's in order to get you functionally back to where you are, not to obliterate the anxiety or obliterate the the insomnia that you have, but to functionally get you closer to what you need to be able to do, and actually to help bridge you to using the non-medication approaches successfully. If you're functionally so impaired with regards to the symptoms that you have, it's hard to engage in non-medication approaches. But once you're able to do that, moving off of the substances is an important pathway.
Right. And while really doctors can't, medical professionals, in your field can't provide patients with all of that, obviously, my hope is that that the patients will take more responsibility on one level. It is up to the patient really to seek these things out, but that the doctor can be more of a partner with the patient and kind of doing a lot of the sleuthing work that can be hard to do when you're in a crisis, of looking back through your medical history, of looking, doing the blood work, looking at things that may be going on in your environment, or anything else that may impact them physiologically or in other ways, and then kind of help direct the patients to these alternative sources, many of which are out there. I'm involved with other nonprofits, the Council for the Sustainable Healing. And of course, I put a lot of this content out on my channel as well, trying to help patients or people who've been on benzodiazepines learn alternative strategies and things like that to heal from these and to deal with these problems long term.
Yeah, you're absolutely right. I mean, all of us basically have grown up in a universe in which medical practice is paternalistic in its structure. You know, I, as the doctor, know, you, as the patient, follows. But what we now know is that that's probably not the best way to do this by any means, and certainly isn't fair, isn't balanced, and doesn't recognize the expertise of the patients that are involved. My wife, I think, said it best, and that is that you, as the patient, need to be the CEO of your own healthcare. In other words, you can't just give that to your medical provider and just follow along. You need to be a director in terms of what you do and how you engage in the various health practices that you do as an individual and health practices that you may access through medical providers. So really, really important. And we're seeing that transition take place across the medical field very, very slowly. But I think it's really important for individuals to take this on themselves and not to give away your power, give away your authority to somebody else altogether, but to be truly partners in your own healthcare.
I agree. And in the long run, that's going to lead to improved mental health and health generally, because, if we can get out of this I am powerless kind of mentality, that I think leads us to say that we have to rely on these authority figures, that we have to have some sort of magic pill that takes it away, rather than saying, you know what, I have options. There's things that I can do to heal myself. That can be much more powerful and healthy in the long run. So
That's right.
yeah. Well, I just hope that this conversation with you today will help patients to do just that, that they'll feel more informed, that they'll feel more confident, that they can go to benzoreform.org and get that pamphlet, that patient provider dialogue, and that they'll be able to go in and start taking control of their health more so, and be more of a partner with their doctors in this.
That's exactly right. Best luck and wishes to everybody that's out there. And thank you for being patient with us in the prescribing community that are slow to figure this out and slow to pay attention to the concerns that are out there.
Yes, thank you, Steve. There's just a lot of patience and forgiveness that needs to go all around for everyone. And I think that'll be most helpful in the long run. So
Mhm.
thank you. Thanks for joining us today.